I'd like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Thank you.
Good morning, everyone. My name's Sophia Ahmed. I'm a nephrologist and one of the new faculty here, and I'm just subbing in for Dr. Kassam, who unfortunately is dealing with an unexpected emergency. But it is my pleasure to introduce to you today Dr. Ross Mitchell. Dr. Mitchell is a Canada CFAR AI chair and the inaugural Alberta Health Services chair in AI. Oh, and Dr. Kassam is now here. So nope, I'm going to keep going. The inaugural AHS chair in artificial intelligence in health. So we're very excited to have him here today. He is a professor in the Department of Medicine and an adjunct professor in the Department of Computer Science at the University of Alberta. He is also a fellow with the Alberta Machine Intelligence Institute and the senior program director of AI adoption with AHS. Dr. Mitchell is the inaugural AI officer at the Moffitt Cancer Center in Tampa, or was rather, because we're very fortunate to have him here now, in Tampa, Florida from 2019 to 2021. He was also a professor of radiology at the Mayo Clinic in Arizona from 2011 and 2019. He was also professor of biomedical engineering, radiology, and clinical neurosciences at the University of Calgary from 2000 to 2011. So we're very fortunate to have him back in Alberta. He received his PhD at the University of Western Ontario and has been working in the fields of biomedical and imaging, artificial intelligence, and machine learning in healthcare for 30 years. So we're very delighted to have him here today. And with that, I'll pass the mic to Dr. Mitchell. Thank you.
Now we're ready to go. So yeah, in my many years traveling around, I've come across a number of challenges for AI and precision health. And to really tackle this, you need at least three things: a big university with a strong computer science department and a really good medical school. You need an AI hub with national level input that gives you connections around the world to all kinds of organizations, and it draws some of the best people to come and be educated. And probably most important of all, or the rarest of all, is population level health data that's comprehensive and covers all aspects of care. So just focus on this for a minute. You're all familiar with Alberta Health Services. I guess most of you are employees of Alberta Health Services. But what's interesting, we're going through the rollout of an Epic system called Connect Care across the province right now. But for a long time, 20 years, the data group at AHS has connected everything in the province, and it's a remarkable achievement. I've never seen it anywhere else, this level of integration. I can't imagine how many different ultrasound scanners they had to hook up across the whole province, but they did it. And so we have a single data warehouse for 4.5 million people going back 20 years. And this is unheard of, and it's incredibly valuable, and we'll touch on it a couple of times throughout the talk. But the main thing for AI is the models you train can be generalizable to other populations, right? If I train a model at Mayo Clinic, we can get some rare diseases. They see lots of rare diseases, but that model's not going to be generalizable to, say, Ontario or Sweden or someplace like that. Because they're not population-based. There's a pretty heavy filter on the door. Not everybody in the population gets to attend Mayo Clinic to be treated, or any of the other prominent large medical centers in the US. So I'm going to talk to you about two things today, and these are really the objectives: to talk to you about what I refer to as a technology push. This is a new technology, relatively new. I've been interested in it for several years now, but it's really exploded with things like ChatGPT coming on the scene. Large language models have been developed over the last several years, and they're going to have a huge impact on medicine. And I'll talk about some of the things that we're working on. And then the other thing I'm going to talk about is inflammatory bowel disease. And this is more a disease or data pull. We have a lot of data in the lab and on the server that we're working with on IBD. And this is generating lots of projects. So start with large language models. Language is hard for computers. So here's a simple example, a sentence: the trophy did not fit in the suitcase because it was too small. What does it refer to? Obviously, suitcase, that's easy. Now, just going to change one word, right? One word in the, you guys are laughing. Going to change one word in the sentence, and I'm actually going to just change the last word. So now what does it refer to? The trophy, obviously. It's obvious for us, but it's really hard for a computer because in order to sort this out, you have to know something about things fitting in other things, and that's way beyond the context of the sentence, right? It could be, you have to know something about the world and how it works in general to figure this out and be able to reliably sort it out. This is called the co-reference resolution problem in natural language processing. And it's been, simple for humans to do, but incredibly hard for computers to do for 20 years until in 2018, scientists at Google described a new neural architecture called a transformer that learns on its own to handle this and many other complexities. So it was originally developed to translate between two languages, and it consists of two main components, an encoder and a decoder. And each of these is a vast, complex machine internally. They're not simple at all. They're incredibly complex. But the encoder basically takes in a stream of words, converts them into a numerical representation, and then passes that on to the decoder, which takes that and generates an output sequence. That's what it is at its basic level. There's some input pre-processing and some output processing as well. And so let's run through an example. We want to translate the sentence, "I like French cheese," into French. And it turns out the original languages that they used to train this thing were English and French. And they actually went to the Canadian government to get their training data. These are the engineers at Google, because everything that's done in Parliament is translated into both official languages at a very high quality. And so they went and got all these years of text from our Parliament and used it to train this model. So this is really good at translating from English to French. Anyways, you pass the words in one at a time. So the word "I" ripples through. We're nowhere near ready to produce output yet. So this actually feeds back in, and that's a key component of this. Now you pass two words in, "I like," and it ripples through. "I like French" gets passed in. "I like French cheese" gets passed in. And then finally, it sees the period, and that says to the system, it's time to generate some output. And now it's ready to do the translation, okay? Handles word order, different languages, all sorts of things automatically. Really cool. So one of the earliest language models that was widely used is called BERT. It stands for bidirectional encoder representations of transformers. What that really means is they just extracted the encoder component out and built a whole separate machine just using encoders. It's published in late 2018, and it has 12 of those encoders in it, and it includes 110 million trainable parameters in the base model. It's massive. It's a massive number of parameters. And it's really good at doing things like answering questions from a passage of text. So it can read a passage of text and look for answers. The answers have to be a continuous sequence of words with no gaps. But if it is, this is really good at finding it. So this is a passage about the Normans from Wikipedia. We're not going to read it, but we can ask questions of this paragraph, like, in what country is Normandy located? And it will go and read it and tell you France. Or when were they in Normandy, 10th and 11th centuries? When did they get their separate identity? And who was their leader, and so on. And when you run this on benchmarks, it performs on par with undergrad students at answering questions on Wikipedia. So it gets about 90% correct. Undergrads, 91, 92. So it's right at the human level for straightforward question answering tasks, which is really cool. So in 2019, when I arrived at Moffitt, they said, the number one thing we're worried about is automatically extracting tumor site and histology from solid tumor pathology reports. Do you think you could do something about that? And I said, BERT. So I used BERT to build a question and answer system, and I had it two pre-canned questions. I asked BERT to read each pathology report and determine what organ contains the tumor and what's the type of tumor. I had to train BERT about the language of pathology. I had to do a lot of coding myself. It took me 18 months to build this system. When I was training about the language of pathology, I said, I need digital pathology reports to do this high-level training. And they said, okay, how many? And I said, all of them. And they said, well, what do you mean by all of them? And I said, when did you start collecting pathology reports digitally? And they said, 1986. Okay, everyone since then. That's what I mean. And a week later, I had 500,000 digital pathology reports, which is really cool. And I could get that fast. I used that to train. And then we had 10,000 reports where we had certified tumor registrars who had done the truth. And I used that to tune, and 2,000 of those were sequestered for a final unseen test set. And that test set included 214 different locations in the human body and almost 200 different tumor types. And across that, my system returns the top 5 predictions of what it thinks the site and the histology are. And the right answer was in those top 5, 93 to 96% of the time. And so we were, at the time I was leaving Moffitt, we were just setting this up so every night it would run in batch and process all the new pathology reports generated that day. And this information would get abstracted and put into a database, and it would be searchable immediately. Whereas certified tumor registrar is about a 16-month lag between the time the report was generated and it was abstracted into a searchable database. So that was really cool. So the really exciting thing recently is the development of ChatGPT, and it's based on the transformer as well. And GPT actually stands for Generative Pre-trained Transformer. So the T is transformer. And ChatGPT uses the decoder. You can think of the decoder as a generator. It takes a numerical input and it generates output. And so ChatGPT is just decoders, just generators. But the pre-training is really critical. So I'll briefly tell you what that is. And in pre-training, what you do is you give the GPT engine a piece of text, large piece of text, many pieces of text, and you ask it to predict the next word in the sequence. So here's our sentence: the trophy did not fit in the suitcase because it was too blank. What's the word that goes in the blank? Well, we know it could be a lot of things. There's no right or wrong answer to this. So how do you figure this out? With a lot of training. So you pass this sentence into the model. The model is huge, and it makes a prediction across every word in its vocabulary. And these models have like 50, 60,000 words in their vocabulary. So for every single one of those words, it'll calculate the probability of that word being in the blank. All those probabilities add up to 1. And if you take the highest ranked one, that's what you select as the missing word. So in this case, it's picked small. In order to get good at this, it has to process a massive amount of text. It takes a long time, but it's fully automatic because we can just randomly mask out a word and have it predict what that missing word is. And by a massive text corpus, the CEO of OpenAI, Sam Altman is his name, said that if you were a proficient reader, if it was your full-time job just to read text all day and you were really, really good at it, and you did it 8 to 10 hours a day, every day, the amount of text would be 1,000 lifetimes worth of what you could read, is what they trained this with. So basically, it's every single word they could find anywhere in digital format. All of Wikipedia, all of the internet, every word ever written in English, everything they fed into this thing and had it learn to predict the missing words. And that forces it to learn a lot about English and a lot of other languages as well, as we'll see. So ChatGPT 3.5 is the version up right now, 175 billion parameters. It's 530 times larger than the system I built to pull stuff out of pathology reports. Think about that. Just incredible. And it cost tens of millions of dollars in compute time to do one training run. So there's hardly any organizations in the world that have the compute facilities and the money to spend to train these models, because it takes many training runs to get them right. So you have like Google and Baidu and Microsoft, OpenAI is part of Microsoft, and so on. And those are the only companies in the world that have this level of technology. And so that's why we're uploading to their portal to use it. This is what we refer to now as a large language model. Typically, I'd say it's anything over 7 billion parameters is a useful large language model. The stuff that I did, I wouldn't consider large anymore. Well, what do you do if you have private data? Let's say you have health data with confidential patient information. You should not be putting that up in OpenAI. I suspect lots of people in Alberta are, but you should not be doing that. Let's see if I can get rid of this. Yep. Well, fortunately, companies like Facebook or Meta have come to the rescue. So in July, they released version 2 of a model called Llama, which stands for Large Language Model from Meta AI. And Llama 2 is pretty incredible. It's open source. You can use it for both research and commercialization. You can build a company around this. They trained it on over 2 trillion words, and they have what they call red teams that get early access to the model. And they bash away at it and try and get it to do nasty things like tell you how to make TNT or things like that. And that goes back to Meta, and they try and train that. They train that out of the model so it can't do that. So it's gone through a lot of safety testing. And then they did blind testing on it, having it do things like answer questions or generate answers to questions. And they used ChatGPT and Llama, and then gave it to people to read, and the people judged the quality blinded as to who generated the output. And the humans rated Llama 2 on par or superior to ChatGPT about 2/3 of the time. So it's right on par with ChatGPT in terms of the quality of the models, quality of the output it produces. But it's less than half the size, 70 billion parameters. That's the remarkable thing. So I can run this on a quarter of we have one of these high-end servers that costs about $500,000. And they have lots of compute power, unbelievable amount of compute power in there. It takes a quarter of one of these servers for me just to load and run this model. And I'm not the only one using this. This is for the whole Faculty of Medicine. It's in DARK, the Digital Analytics Research course, so it's behind a firewall and very secure. And we're working with Alberta Health Services to get a legal agreement called an information management agreement that will allow us to put confidential data, including patient identifiable data, on this system. And we hope to have that signed away fairly soon. So with this system behind the firewall, I'm building several proof of concept applications, and I'm going to go through some of them now for you. So one of the first things I did was build what's called a document chatbot. We all know what a chatbot is, but a document chatbot, you can ask questions of a document or a group of documents. And you constrain it, you put guardrails on the system, and you say, your answers must come from these documents. You're not allowed to go out to the internet. You can't make stuff up. You either find the answer in this document, or you say, I don't know how to answer it. And the document I decided to use was Harrison's Internal Medicine, not the current edition, but close enough, about 4,000 pages in PDF form. So the code I wrote is 4 major steps. First thing, I read in this 4,000 page PDF, extract all the text, and record the page numbers. Then I use my large language model to what's called embed each page. And what that is, remember, the large language model takes text in, it represents it numerically inside. That numerical representation is a valuable representation of the text. So we pull that out. We don't feed it to the decoder to generate something. We pull that out and say, store this. This is valuable. So that numerical code reflects the content and the meaning of that page. And we store these numerical codes in a special database. So we do it for every single page. Then I prompt the user for a question, and I use that same mechanism to embed the question. So now I have a numerical representation of the question, and now I search the database for similar embeddings, and I pull the text out, and those texts all have something related to the question on them. That's what this whole process is. And finally, I ask the LLM to summarize. Okay, so this is all. You can see how heavily dependent this is on fast hardware and these large language models. So here's an example. What is hypernatremia? Who here knows what hypernatremia is? Everybody. I figure most of you probably have this textbook memorized, all 4,000 pages. I didn't know what this was. I just scrolled through and found a random page and typed this in. And this is the response that came back. And this is how long it took to get the response, right? It took 2.29 seconds. It took 2.5 seconds to print that out. And it lists the pages that it found the answer on. And I went through and looked at those pages, and sure enough, that term and some description of it was on every single one of those pages. I don't know if it was on other pages, but it for sure was on each of those 4 pages. And what's cool is look at how different the pages are. There's a cluster around 3,000, and then there's some, so it's looking across the whole text simultaneously, and in 2.5 seconds, giving you this response. So then my next question is, okay, how should it be treated? And the tricky thing here is the word it. What does it refer to? Well, obviously hypernatremia, but in order for this to work, I had to give it what's called a chat memory. So I built that into it. I gave it a chat memory, so it remembers everything that you said and can go back and infer things. So this is the answer, and this took 5.5 seconds to find. And it found it again across a cluster of pages. So this is now running, and my question, this is more of a proof of concept. Is this useful? It might be useful, I could see, for someone who's learning medicine, because even if you had the digital PDF copy on your iPad or your phone, it would take you more than 5.5 seconds to look this up. And you wouldn't look across the whole book. You wouldn't look at page 450 and at page 3646, right? So this is just like, but the cool thing about this is it's not just restricted to one PDF or even PDFs. You can have entire collections of documents. And there's over 150 different types of documents that are supported. Microsoft Word, Excel spreadsheets, PowerPoints, web pages. It'll read captions from YouTube videos. It'll do email. So let's say you're a department chair and you have to look at 500 year-end annual reports and you want to get some summary of what's going on or answer a question. Who was it who did this again? This sucker would find it for you in 5 seconds, right? So based on that, I then went on to build what I call a prompt playground. So this is running behind the firewall. That's the web page. It's too small to read. We're not going to go through it, but that's what it looks like. And this allows you to load in. You basically give it a CVS or an Excel file with your documents in it. So one of the columns in the spreadsheet is your passage of text. And it pulls that out and puts it up on the web page and gives you prompts that you can tune and play with to ask questions and try and get information out of that. And once you're happy with the answers that you're getting, you click submit and you get the answer back. Once you're happy with those answers, you can say, okay, now go do all of the rest of the documents. And it'll go off in parallel and do all of them and produce an Excel file and put it on a secure Google Drive and email you the link. And so in the matter of a minute or so, you can process thousands of documents. If you have a collection of documents that you've had for years and they've been labeled or something, this is a way now that you can use these language models without having to be a Python programmer. And that's the goal. We want to make this technology available to everybody in the Faculty of Medicine so that on the weekend you can play with your documents and start finding patterns about the patients that you're seeing. So this is a real example. This is the prompt preface. So that's part of what these are high-level overarching guidance that you provide to the language model. And I say you're an experienced nurse. And it was interesting if I changed that to doctor, I got different responses. And so there's lots of biases built into these models you got to be careful about. Use the following clinical note to answer the user's questions, provide details. That's an important thing to put in there. If the answer is not provided in the following clinical note, attempt to infer the answer based on other information in the note. That's important to have in there too. So here's, this is a group of public domain cases that are available for download. I didn't want to use real Alberta patient data for this part of it. So, but this is not Alberta data, but it's a real clinical note. So it's a woman who's developing gestational diabetes. That's what the note is all about. So I played with this for a while and came up with this prompt. And a prompt doesn't have to just be one thing. It's in point form and asking it to answer a bunch of different questions here. And like you can fiddle with the prompt preface and you can fiddle with the prompt itself, and you keep doing this until it seems to be giving you good answers. And for this, what gets passed off is the preface, the text, and the prompt, and then you get this back. So it says, the doctor's specialty is not explicitly mentioned in the clinical note. However, based on the information provided, it can be inferred that the doctor is an obstetrician as they are doing an ultrasound exam of the fetus, right? That's pretty cool. They can figure that out on its own. Major finding is the patient is developing gestational diabetes, and it lists the procedures that were performed, the organs that were examined. The age is not provided in the clinical note. The gender is not explicitly mentioned, but it says we can infer that the patient is a woman because she has a uterus. Good tip. But it's good that it can figure that out, right? So, and these things could now be abstracted and put into a database. Like we could build a structured form and you could convert this into a structured form of data that you could use for processing if you wanted to. Very easy to take those results. In fact, I can say to the algorithm, return your answers in JSON format. And if you're a programmer, you know what JSON is, and that's immediately readable by code. The next application is chest CT for pulmonary embolism. And this is Jake Hayward, who's an eMERGE doc here, came to me and said, we want to do a quality project to determine if we're ordering too many, too few, or just the right number of CT scans for PE. And I don't think I have to tell you guys what a chest PE is. So I'll just skip through this. If you sit on an airplane for too long, you can get a clot in your leg, and that can be trouble when it gets to your lung. So like I said, he wanted a way to screen these, a mass way to read these. And he said, do you think you could do it? I said, okay, I'll try it with my prompt playground. So he has a med student who's labeled 10,000 of these things. And she can label them as either the radiology report says yes, it says no, or it says unknown. Those are the three possible answers. So I took 1,000 of those. I started with 100, did some prompt tuning, then applied it to 1,000, then did a second round of prompt tuning. And then I finally applied it to completely unseen further 1,000. I haven't seen them, the radiology reports, and neither has the model. So here's an example of some of the case reports. I'm going to ask you to play the role of med student labeling this. So this is the entire report. 1, no pulmonary embolism. That's a tip. That's a key right there. 2, mild pulmonary edema, and then 3 and 4. So who here thinks that this says there is a pulmonary embolism? Who thinks there's no pulmonary embolism? Pretty much everybody. And who says unknown? Nobody. The med student in this case actually said positive. And you go, what? How could? Well, she had to do 10,000 of them. She's not getting paid. It's probably a Friday night. She's come back from the bar. God, I got to get more of these darn things done. She's human. We're all human. We make mistakes, right? So that happens. It doesn't happen very often. I mean, she's really good, but once in a while it happens. So the model, of course, said negative. But the cool thing about this is I said, I don't just want your prediction. You got to explain to me, justify your decision. And so it also produces this justification that does not mention the conditions listed. There's a bunch of them I ask it to look for. The note specifically states no pulmonary embolism in point 1, and the rest of the note describes other findings unrelated to these conditions. It's cool that it knows that the report is in point form, and it knows a lot. And this model, by the way, is off the shelf. I haven't done any tuning. All I'm doing is adjusting the prompts. It knows this, comes prepackaged with this knowledge. Okay, here's the second and last one. Very limited study due to patient compliance, best images possible, no definite central pulmonary emboli are seen. That's a tip. Small segmental or subsegmental emboli difficult to exclude due to the limits of the scan, bronchial wall thickening and other stuff. So who thinks that this is positive? Who says negative? Who says unknown? The med student said negative, and the model said unknown, and justified it by saying, you know, this indicates the presence of pulmonary embolism or other related conditions cannot be definitively confirmed or ruled out due to limitations of the scan. Therefore, the answer is unknown. So the model was right again here. So when I applied this to the 1,000 unseen, it agreed with the med student on 982 of the 1,000. And for now, we're going to assume that if they agree, they're probably both right. There'll be a couple of cases where they're both wrong, but we have to do a consensus read, and that's still underway. So for the time being, we'll assume that those 982 are correct. I'm really interested in the 18 where the model disagreed with the med students. I went through those by hand, and I determined that the med student was right on 3 of those. The model was right on 13, and they were both wrong on 2 of them. But what that means is that the model either agrees with the med student or produces a different but correct answer 99.5% of the time. So that's a pretty good secondary read. It's probably better than the med student. In fact, it is better than the med student. And what's cool about it is it takes 150 milliseconds per report for it to read it, come to its conclusion, and produce the text justifying its conclusion. And so this now produces a CSV file with 10,000 predictions and 10,000 justifications, which Jake can then take and do things with. And it only takes less than a minute to process the whole 10,000. The other thing I've been interested in for a long time is assisted documentation. And this is a dream I've had where we have an AI agent listening in the background as you have a conversation with a patient in an exam room. And at the end of that conversation, your note is automatically created. As soon as you walk out of the room, the note is created. Wouldn't that be great? Well, the technology is now here. And in fact, I built it. Okay, so this is now running behind the firewall. And to build it, I didn't want to use real Alberta data or anything like that. So I went out and searched, and lo and behold, last year, a group of colleagues in Ontario published this paper in a good journal. And it's a data set of simulated patient-physician interviews. And so I downloaded this and used this to play with the model. And here's what a typical, there's 272 of these in the data set. And here's what one of them sounds like.
What brings you in here today? Yeah, I've just been feeling breathless and it's getting worse. So I wanted to check it out.
Okay, and when did you first start feeling breathless?
About 2 months ago.
Okay, and did it come on about like gradually through time or suddenly just happened?
I guess gradually, yeah.
Okay,
So we're not going to listen to the whole thing. It goes on for 12 minutes. But what I did is I took one model, and that model listens to the first 30 seconds and identifies the language automatically. It handles a bunch of different languages, converts the audio to text, identifies each speaker automatically, and then synchronizes the text with the speech. So this is what you get out from that.
what brings you in here today?
Yeah, I've just been feeling breathless and it's getting worse. So I wanted to check it out.
Okay, and when did you first start feeling breathless?
About 2 months ago.
Okay, and did it come on about like gradually through time or suddenly just happened?
I guess gradually, yeah.
Okay, and do you feel how often do you feel breathless?
I'd say it's worse when I walk more than 50 meters. Um, that's kind of the main trigger, just exertion.
Okay, and were you able to walk normally more than 50 meters before 2 months?
Yeah, 3 months ago I was fine.
And again, it goes on. So after that's done, we get this transcript back with the labeled parts. And here's where we got to in the transcript for all that listening. And this goes on for quite a while, of course. This isn't even the whole transcript. There's more to it than this. So then I take this transcript and I pass it on to my large language model that I have running. And I say, please summarize this conversation, highlight the important clinical information, and list any meds. And this is the literal output that I get from this. And if you read this, it's a good note, I think, but we need to do some validation and testing on this, but it'd be pretty straightforward. You basically turn on a microphone on your web browser, and when you're done, this will be available for you to check and then paste into ConnectCare for your note. And a 12-minute recording to label it and produce the note takes 22 seconds. So this would be ready by the time you walk out of the room, basically. And so this would be really cool to start a trial to train it here and hopefully reduce your documentation time. And also, the other thing is, I imagine most of you, when you're doing your documentation, it's late at night, it's like 9 o'clock, you just put the kids to bed, you're having a glass of wine, and you're trying to do your notes and think, now, what did I say? What did we discuss at 8 a.m. this morning? Right? Wouldn't it be great to have this done automatically, right? As soon as you walk out of the room and you just check it and paste it into ConnectCare?
Spelling it. It's interesting that it did.
That's neat because if you listen to the whole thing, she actually doesn't call it simvastatin. She pronounces it incorrectly, but it figures out that that's what it means. So it's interesting. Yeah, things like that are interesting that we want to check, right? So I'm not, by no means the only person interested in this. Oracle, who bought Cerner, the main competitor to Epic, has advertised this. Epic is giving demonstrations to the folks at AHS. They licensed the technology from Microsoft. This is coming to Epic for sure. But if you look behind the scenes, both Cerner and Epic right now are relying on humans. So they advertise and show a great demo, but behind the scenes, they have hundreds of people checking everything at every stage of the process because they're worried about the legal liabilities. And this is where I think we have a role to play. It's not in developing the technology. It took me 2 weeks to build this system. It's not difficult to build this anymore. What's difficult is to validate it clinically. So we actually have data from patient-provider interviews, human-generated transcripts, and provider-generated summaries of those transcripts. But our N isn't 272, it's just over 1 million. And we have this data on DARK right now. And what it is HealthLink calls. We have 1 million HealthLink calls. We have the transcripts, and we have the summary of those calls. And this would be incredibly valuable to a company like Cerner or Epic for validating their system. What would it be worth to them to be able to do this? And we have the technology to do it. Plus, I would like to do it in the clinic with you guys, so you get that real world feedback, right? this would be a really cool project to do. And I think idealistically, imagine if we could reduce your documentation time each day from whatever it is now to 10 minutes or less, and you're done. And maybe even have higher quality notes. How much of time would that free up for you? And that's time you could spend with your family, doing research or seeing more patients, right? Could have a huge impact on healthcare in Alberta. Okay, so that's part one, the technology push. We're doing a lot of cool stuff with large language models. The second part is inflammatory bowel disease. And we have a cohort of just over 92,000 patients who've been diagnosed with IBD over an 18-year period. We applied a very strict published definition of what IBD is, and that reduced our cohort down to 30,000 patients. Half and half, male, female, roughly 41 years old, typically. And what's interesting is an average of 3 ER and 0.2 hospital admissions per patient per year. And if you work that out, it's 1.6 million admissions over this cohort. That's a lot of admissions. And we have all kinds of stuff about these patients, the diagnostic and procedure codes, we have their images, discharge summaries, we have all this stuff about these patients. It's an incredible data set. And so I was looking at this and I was actually going through the discharge abstract database, and I'm looking at this going, how do you make sense of this? And if you're not familiar with this, you probably are. This is what a discharge abstract database, or the DAD, looks like. Has dates, a patient ID. In our case, this is not the real patient ID. It's made up. This data is all anonymized. Has the primary ICD-10 code that lists why they were admitted, why they were in the hospital. And then it lists any additional ICD codes that are other conditions that they have at that time. And you can imagine that there's hundreds and hundreds of thousands of rows in this over these 30,000 patients over 20 years. And I was looking at this going, how the heck do you make sense of this? And I thought, okay, I'm a data scientist, let's do data science. And so I said, the obvious way to do this is with a network analysis. So I coded it up. And then I gave it to smart grad students who took it and ran with it. But the essence of this is, let's say we start with the primary code and we form a pair by matching it with any of the other additional codes. So that's one pair. There's a second pair, and so on. And then each of those we can conform pairs with too. So each row in this database, we extract all the pairs of codes, okay? Now the network, each node in the network is an ICD code, and the line connecting them reflects how frequently that occurs in the data set. Does that make sense? The thicker the line, the more frequent it is. And then I applied a common clustering algorithm to automatically separate this into communities. And this is used it's a highly cited algorithm, been used for years and years. And I'd like to show it to you. This is what it looks like. This is a couple 100,000 entries in a discharge database. And it's hard to see in this form, but you can zoom in and you can see codes. If I hover over this one, it'll say whatever that is. And it tells you there are 32 patients that had this. The big ones are, this is IBD. So all these patients either have Crohn's or colitis, right? And you can see the thickness of these connections here. And what's neat about this is it's fully interactive. So I can grab this and just drag it out. And I can start looking at these things and pulling this apart. But and then down below here, I have the data listed. So I can sort these things by the number of occurrences. And I can also sort by the number of patients and whatnot. So we've got both a spreadsheet and the visualization. And this was all done by Jerry in my lab, a bright grad student who built this web page, and a scientist of mine who did a lot of the processing to extract the information out. What I'm going to do, you can select IBD or just Crohn's or ulcerative colitis. You can group by ICD code. If you want to see the ICD codes, the color will correspond to the code group. But here I've asked the clustering algorithm to identify the clusters. And what's interesting is you can see that this guy down here is Crohn's. And this one over here is colitis. It separated the two automatically. Even though they'd be together in the ICD coding system, they'd be under the same general heading. It's figured out by the comorbidities that these are separate. To get a better visualization of this, I'm going to turn this down. So I'm moving up the hierarchy of the ICD codes, right? Instead of going to the full resolution, I'm going a couple levels up. So we're grouping codes together. And I'm also going to get rid of sort of incidental connections. and you can generate a new plot. So this is like the skeleton of what you just saw. And this really tells you hopefully the important information. So this is Crohn's. Let's just pull this out. And this guy is colitis. Actually, I'm going to put this one back because. And one of the first things you notice is, I'm going to get this guy out of here. The colors are the clusters. So it's automatically applied these clusters. And the way it does the clustering is it tries to find choke points in the network and says everything on that side is one cluster and everything on that side is another. And so that means that those choke points are typically the big spheres. The size of the sphere indicates how many patients have that condition. And the thickness of the line is how often the pairs occur. But if you look at this, you see these two big thick red lines between Crohn's, and this guy down here is anxiety, and this one over here is depression. So these are actually the most common comorbidities of Crohn's patients. And I don't think, like, I'm working with Daniel Baumgart on this, and he says this is previously unknown. Like, it's not really known. They know people have it, but they didn't know it's this prevalent. And it's different for ulcerative colitis. They still have it, but to a lesser degree. And there's other things that pop up in here, like there's all kinds of rheumatoid arthritis and asthma. And you can, I'm just going to zoom in here. This guy here is, oh, that's GI as well. But if you, the other thing is if you hover over something like this line here, find a thicker one. It's a little harder when you don't have a mouse. Okay, so these two, this is depression and anxiety are connected 3,500 times. We actually have directional information. It's not showing because it's too heavy for the plot, but we actually know which comes first. And so this is saying to me that of the 3,500 occurrences, they were in for, I think it's F41 was the primary reason for admission. And they also had F32, 2,100 times. They were both ancillary conditions, 1,000 times. And they were admitted for F32, but incidentally had F41, 342 times. So it's overwhelmingly they're coming in for F41. And the next cool thing about this is to do work is because we know all these numbers and we know the directions, this is actually what's called a Bayesian belief network. And we can use something called Markov chain reasoning to answer questions. You can say, my patient has the following symptoms and check them off on the list. What are the chances they have this? And it'll tell you the probability immediately. And it'll go through the whole network and figure out any connection between any two symptoms that you want in your patient and tell you what the odds are that they have that, right? And they can explain and say, well, the reason they're having this is probably because of this group over here, and you may be thinking it's because of that. So it'll let you do what if type things on your patient population. So that's the next stage. We're going to save that for another publication. This is almost ready to go out. We're almost ready to submit this. But easy to do. If you have a discharge abstract database, pretty straightforward to build this for your patient cohort. The next thing, last thing I'm going to talk about is imaging. And on our cohort, we have 58,000 patients with images over a decade, almost 3 studies per patient for a total of 160,000 abdominal CT scans. It's an enormous amount of data. And I got interested when I was talking to the gastroenterologist. Of course, they're worried about inflammation in the gut, but there's no quantitative biomarker because it's just too hard for an endoscopist or a radiologist to go through the video of the endoscopy or the CT scan and try and measure and count all the pieces of inflammation in the whole tube, right? It's just way too time consuming. So they know if the patient's having a flare-up or if they're in remission, but beyond that binary classification, they don't really know. They don't know that this patient is, at a 0.6 level of badness versus a 0.8. And if you don't know that, how can you measure the effect of interventions, right? If all your outcome is purely binary, your intervention has to be sort of all or nothing. You can't see that you're improving the patient by 20%, right? You can't make that sort of a measurement, or substratify your patient population based on the degree of response. So there's all kinds of things we can't learn until we have a quantitative biomarker of inflammation. This is a perfect application for deep learning. So our goal here is to extract the tube, as I say to the grad students. We want the entire intestinal tract extracted automatically. We're going to lay it out flat, and we're going to go through exhaustively and measure all the inflammation in it and come back with like a normalized measure normalized by body mass or something like that. We'll have to figure it out so you can compare between and within patients over time the degree of inflammation. And so I started building this about a year ago. I built a pipeline, and it takes the files off the scanner, gets them all ready, and uses an existing open source segmentation tool. I don't want to reinvent the wheel, right? We want to solve problems in the clinic. I'm not interested in reinventing wheels. Went out and found this really cool tool. And so it runs on our high-end server and extracts the intestinal tract. And so when you start scaling things up, the science changes. If you do this like 10, 20, 30 times, it's one thing, but if you want to do 160,000, it's another. And so I built the pipeline fully automated, and I fired it up one night and went to bed, got up the next morning, and it completed 1,090, but in 4 hours. So that took 14 seconds per exam to do this extraction, which is pretty cool. That's fast, but if we had to do our whole data set, we'd have to run this whole system, use it for a month, nonstop. Nobody else could do a thing on it. Just not possible. 1,090 is kind of a weird number. You may wonder why that number. Well, that's because after 1,090, it filled the massive storage array on this supercomputer. I filled it. So the program crashed. My server didn't crash, but my program stopped because I got no space to write the output. So for just to process the data, I need 160,000 times more storage than we have available on our system, a $500,000 computer. And the storage has to be fast because we're going to use this to train models. The program's called Total Segmentator, and I've now updated it to version 2. And these are the structures that it automatically extracts in the 14 seconds. It's not just the GI tract, it does everything. And so what I would like to do is do this for every single CT scan that's ever been acquired in the province of Alberta and every abdominal scan going forward, and put it in the data warehouse so that as a clinician or a scientist, you just know that the volume of every organ in that patient has been measured and is available. Let's say you want to know if your patient's kidney volume has changed over time. Trivial, we've got it. Right? Let's say you think the liver volume, you're interested in that, trivial, you've got it. And you've got it for 20,000 people, right? That's what I want. But we got a ways to go in terms of infrastructure to do this. Or let's say you're calculating EGFR and you want to know the muscle mass. Well, we got the muscle mass. We're segmenting all the muscles. So now you can do some calibration. And it also does these other things, like it'll measure, it'll do the skin, hip implants, look at the lungs, effusions, hemorrhages, and more and more and more. But one thing that they don't do really well, and they say in their paper, is segmenting the intestinal tract. This is one of our patients. This is a Crohn's patient in Alberta, and this is the output from this system. And it's beautiful. You can see it's done a nice job of delineating all these organs. And you can scroll through this. There are the kidneys. And so when you actually look at the intestinal tract, it's good, but it's not great. And so you can see here, there are a bunch of errors. So it's labeling some of the visceral fat as part of the intestinal tract. It shouldn't be. It's mislabeling some things. And so the goal is to build a system to allow experts to correct the errors. They don't have to segment from scratch. They're going to start with the baseline AI segmentation, and they're just going to fix up some of the errors. So that's the second project I've been working on. I built a whole system now that will allow people in general to correct AI errors from Total Segmentator, not just for the gut, anything. If I want to do another, I just have to change a text file and say, I'm not here. I said I want the duodenum, the jejunum, and the colon, and the stomach, I just change that to like kidney and liver, and this whole thing will pop up with the kidney and liver ready to tweak. So any organ can be done now trivially. And this is, I corrected the errors, and this took me, 10 minutes or so. We're going to try and speed that up. And you can see it looks a lot better. It's smoother. It just looks a lot better. Corrected a bunch of the errors. And I've actually got this running on AWS. So it's running in the cloud. And right now today it's running in Montreal and it's running in Frankfurt. And this is what it looks like running in the cloud. So I built a worklist manager, so you don't have to type anything in. You just sit down and go next, previous, next, previous. It does everything for you. And every time you hit next or previous, it saves and backs up everything in the background on AWS. This is another open source piece of code. Again, I'm not going to reinvent the wheel. This has been developed for 20 years by people around the world. It's like Photoshop for 3D medical images. So this is the core of it. I control it. And then the whole thing is running in your browser. So you can do this anywhere in the world. That's the goal at any time. And this is what it looks like. So I'm in Edmonton, and this is all running on the Montreal node. And you can see that it's good interactivity, even though we're half a continent away. You can scroll through, and I can see an error there already. We'll get to it in a sec. There's part of the colon that's been labeled jejunum. So that dark blue thing there should be light blue. So I click on it, it automatically snaps to where that is. And I go over and say, okay, I want to paint this in 3D. I want to paint it and be light blue instead of dark blue. And because I'm constraining it to the tissues, I don't have to be very particular. I can just quickly go in and scrub it in 3D like that. And it's fixed. So that error is fixed. And I can go through and do that. And we're going to build some more automated tools to make this even faster. When I'm done, I just hit next, and the next case gets loaded up. And when I'm done, I just go and sign out, and I'm back to my browser. So the goal is to recruit radiologists from around the world to help us label several thousand of these cases that we have. And when we've done that, we will build the world's definitive model for segmenting the gut. No one will be able to even come close. Total Segmentator was trained on 1,200 scans, and version 2, they're very proud. They got that number up to 1,500. And I'm kind of dread writing them an email and saying, how'd you like to help us segment 160,000? So nobody in the world has data like we have. Absolutely nobody in the world. And this is a point of proof. So just over a year ago, September 21st, 2022, Chan Zuckerberg announced this is a blog on their site, supporting UK Biobank to create the world's largest imaging data set to understand disease. And what they want to do is enroll 60,000 participants, all the participants in the UK Biobank, and get them to agree to have a second abdominal CT scan. So they get one when they enroll, baseline, and they said it would be useful to have a second one later in life. So they're going to have 120,000 total after they're done. And it's going to take them about 5 years to collect this data. And of course, it's, a worthy cause of, yes, it's going to help us understand the trajectory of chronic diseases. To do this, they got almost 50 million Canadian dollars to acquire these 60,000 scans for a total of 120. I've already got 160,000 scans on DARK of abdominal CT, just of inflammatory bowel disease. This is all comers, all diseases. They're hoping to get 120,000. So I've been bugging the university to phone Chan Zuckerberg and say, what do you give us? I can't even process them. I need about $1 million to process in storage and compute to process the 160,000. Can you, Chan Zuckerberg, could you give us like 10 million? Would you pay for our AI hub for 5 years, give us $5 million a year for 5 years or 10 years, and we can do this and a lot more? But the world doesn't understand what Alberta has, right? Why are they going to the UK Biobank, and why are they saying the world's largest imaging data set? I chuckled when I read that and said, nope, just isn't, guys. So that's it. So in summary, I told you about two things, a tech push and a disease pull. And I hope you got something out of that. There's lots happening with large language models. And the final thing I'll say is a quote from Sam Altman, the CEO of OpenAI, who built ChatGPT. As hyped as AI is right now, he still thinks it's underhyped. Amazing. And I actually kind of believe him, especially in healthcare. Thank you very much.
Amazing, the amount of work you've done in the short time you've been here. I mean, you've been here since what, has it been almost a year or?
No, I started bidding at 2022. So
Right.
about a year and a half.
Yeah, that's pretty amazing. There's lots of questions here. We don't have much time, but I just have a really quick one, which is around the data extraction. We know that as clinicians, we are terrible with entering information in our database, in our patient charts. And,
Yep.
you know, the extractors are great. They go through and they pull things out. But how do you account for that incomplete information? You know, the old garbage in, garbage out sort of?
Yeah, so you really can't. In fact, it's a worry because if you don't put guardrails on the system, it will generate stuff that could be even worse garbage.
Yeah.
Right? It could be a garbage amplifier. So you really have to put the guardrails on. And that's really what we're focused on is like with the document extractor, telling it must come from this book. You can't look, you know, I'm not allowing it to go to the internet and search. So that's part of what the research is the validation. And that's the key to a lot of this stuff is validation and putting guardrails on it. And also measuring the clinical impact, like why do it if it costs more, ends up costing the system more. So we want to take some low-hanging fruit that we think are going to be big payoffs and then validate and justify them and translate them.
There's a lot of by the way, you and I need to talk about those 250 annual reports.
Yeah.
But there's a lot of questions around the generation of language. So Wendy Johnson asks about a plan to circle back to the patient to check acceptability and accuracy of the transcript. But I mean, I suspect that's just like any documentation we do, right?
Right. So the point here is to speed up the documentation, not to replace it. So the physician would still have to sign off, right? Like the way I envision it is you would copy and paste into Connect Care, and then it's essentially you now putting that text in. You're just being helped, but everything else still applies. It doesn't short circuit any of that. We don't want that.
Yeah. And Nikhil asked about the demo that you gave. Do you get better output if the interview is structured as opposed to being free flow? Has anyone looked at that?
No, nobody's looked at it as far as I know.
Okay. Any other questions in the audience? Scott?
I just had a question about, you know, we hear a lot about hallucination of these models. Is that why you have the guardrails on?
Right.
Or whether they're,
yeah.
And then, you know, a lot of these things, think about it like an evidence-based approach to studying these things.
Yep.
But they're going to just, like, are we going to be able to have trials or studies where we look at outcomes? You mentioned kind of the cost and the patient-important outcomes or validity-related outcomes.
Yeah. So the question is first about hallucinations. These models do hallucinate. They're getting better and better at not doing that. It's a problem now, but I think in 2 or 3 years, it's not going to be much of a problem because they're really worried about it and they're putting billions of dollars of research into it. But we still need to put guardrails on them regardless. So our attitude is that this is an intervention that affects patient outcomes, and therefore it needs to go through a clinical trial. It needs to be validated. You wouldn't give a new drug to a patient. And this is a drug that can possibly learn and change its behavior over time. So it's even more dangerous in that aspect. So the key thing for AI in healthcare is the validation, and it really comes down to building trust. How do you get the provider and the patient to trust this intervention? And you have to do everything that you've done. You don't just flip the switch and turn this on. You run it in silent mode. You collect data, retrospective analysis. We do an implementation study, measure the costs, measure the impacts. The vast amount of the work is the translation into clinical impact, not building the models. I can build this in 2 weeks, but we could spend a year validating it in the clinic. And we should spend a year validating it in the clinic. We need clinical trials of this technology.
I know it's 9 o'clock and there's a couple of questions here, so I hope it's okay to stick around and answer those. You know, we recruited Ross with the view to building capacity, and I know he's gotten really overwhelmed in this last year and a half, but I know he still answers emails. So just reach out to Ross and any questions or you know, sort of things that you want to bring forward. So on behalf of the department, thank you so much, Ross. You're doing an amazing job. And I just, you know, we have to get you in here every about year and a half to give us updates on where things are.
Yeah, because guys like Sam Altman are doing crazy stuff, right? Like it's just nuts.
Lama too, got it. Yeah. And thanks, Sophia, for opening us up.
Thank you.
Okay, thank you.